Okay, good afternoon, Pam. Kerry Reid Sells my name. I'm your nurse this afternoon. Pam, I'm just wondering, is it okay if I take your vital signs?
Sure.
So Pam, for this being the purpose of an educational video, I'd like to be able to talk through what we're actually doing. Is that okay with you?
Great.
So I've started with my 5 moments of hand hygiene. I just need to double check your identity. So
Sure.
can you please tell me your name?
Pam Maskell,
Yes. And date of birth?
24th of February 1977.
That's right, and your UR number is 824632, so that's you. So I'll start first of all with your pulse.
Yep.
So when I'm locating your pulse, I'm using here the radial pulse. You've also got the brachial pulse here, which I'll be using today for purposes of vital blood pressure. I'm not going to go into the rest of the pulses for this purpose of this demonstration. So in terms of locating your radial pulse, we go right here along the thumb, and I'm doing this for a total of 60 seconds. So I've got my second hand watch here, and I'm feeling for the rate, the rhythm, the regularity and the strength. And I'm timing from now for a full 60 seconds. And so I've got that, and the rate that you have is 62. I'm going to just write that down. I'm now going to do your respiration. Pam, this is normally an observation that I wouldn't tell the patient about because it's one of those things that you can consciously change your respiratory rate. But what I am going to be looking for is your rise and fall of your chest, which equates to 1 respiration. I'm also going to be looking at any use of accessory muscles, any signs of cyanosis, your work of breathing, your effort in breathing, and I will also use a stethoscope to actually have a listen to chest sounds if I'm concerned. So when I'm doing the respiration, I normally just continue holding onto a patient's arm when I'm doing their observations or their pulse and watch the rise and fall of the chest. So I'm just starting that now. Again, I do this for a full 60 seconds and I use my watch with a second hand. And so on the breath in and out is 1. And in and out is 2. So I've done that for a full 60 seconds and your respiratory rate is 14. Additionally, I'd like to have a listen to your chest to make sure that the sounds are okay. Excuse me. So I'm going to breathe in and breathe out. Thank you. And we'll go this side. Breathe in and out. And I can move down either side of the chest, and I could also ask to lean forward and rise in and out, in and out, in and out, in and out. Thank you. So again, the rise and fall of the chest equates to 1. So your respiration there was 14. That's right. So the next thing I'd like to do is your blood pressure. So in order to take the blood pressure, I need, of course, my sphygmomanometer. I need a stethoscope, and I'm going to, first of all, ensure that the position of your arm is correct. So I need to bring your 90 up, because with manual sphygmomanometers, I don't want to be doing these over clothing, and I do need to be able to access the brachial pulse. I've got your arm there on a pillow just to ensure that the level of the arm is equal to the level of the heart. If I've got your arm up too high, I can end up with a false reading, as do having your arm hanging down low. So I place the cuff of the sphygmomanometer over your arm, and I'm locating here the brachial pulse. So that's the brachial pulse right there. I then place the cuff over with the line of the sphygmomanometer right there on your brachial pulse. You'll notice that I'm trying to also look at the size of the cuff. The size of the cuff should be at least 2/3 of the arm. If it's too narrow, I can get a false high reading. If it's too large, I can get a false low reading. So I place this around the arm. Thank you, and just relax. I'm now going to locate the brachial pulse, and I'm going to decide how far do I inflate this cuff. So to inflate, Righty equals tighty, that's compression. Lefty equals loosey, it lets it off. So I'm going to inflate now, but how do I determine how far to inflate? I simply put my hand over the brachial pulse. I feel that brachial pulse and I inflate to the point where I can no longer feel the brachial pulse. And it's disappeared at 110. So it disappeared here. I know now that I need to inflate it 30 millimetres of mercury above that 110. So I'm going to inflate it to 140. At this point, I place my stethoscope over the brachial pulse. I cannot at this stage hear anything. There is no sound until I start to inflate it. When I do inflate it and let it down, I will hear different sounds, and these sounds are called the Kortikoff sounds. The first sound that comes in will be representative of the systolic pressure, meaning the maximum amount of pressure being ejected from the heart against the vessel walls. The diastolic is the bottom reading, and that is when the heart is ventricles are relaxing, refilling, and it's the least amount of pressure against the vessel walls. So let me just do that now. So I said up to 140. So righty equals tighty. Up we go to 140. I then slowly let the cuff off, and I will hear pull, 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 gone. So I heard the first sound at 120, and I heard the last sound at 70. So the systolic reading is 120, and the diastolic reading is 70. Thank you, Pam. The next thing I want to do is your oxygen saturation level. So with this one, we're looking at the oxygen uptake at the capillary level, and I'm basically using a piece of equipment that will show me both the pulse and the oxygen saturation level. There is usually a rhythm on these monitors that will indicate to me that it is a good reading. If the rhythm is not effective, then you could have a false reading. So these simply go on to the finger and ensuring that the finger is nice and warm and also free of nail polish. So we can see here 2 readings coming up, and we've got a nice rhythm there, which is fantastic. And so I have got this upside down, so I'll just so I had 97, we'll just put that back on so you could see, just for the sake of the looking at this, right, so we've got 95, 96 and a pulse rate of 64. So we'll put that as 96% oxygen. So alright, so we'll take that off. The next thing I want to do is your temperature. So I'm doing the oral temperature, meaning with the ears. So this goes simply on here, and that will trigger this monitor to actually go on, and I simply place it with the, hold the pinner of the ear up, point this gently in towards the nose and press, and there's my reading at 37.5, which is a bit of a low grade temperature. So I'm going to write down 37.5. I could, if I wanted to, do a oral thermometer temperature. So this one would go under the tongue. If I'm using an oral temperature, then I need to ensure that I'm putting a cuff over this, and because I am dealing with saliva, then I would make sure that I'm wearing PPE and gloves. So that simply goes under the tongue. I could also use this under the axilla. So if somebody has got a contraindication, such as they've had mouth surgery, they've had drunk something cold or hot, or you've got a child that's not likely to be able to tolerate that, then they can go under the arm. So I've now got the observations basically done. I want to also double check, Pam, have you got any pain at the moment? meaning 0 being no pain to 10 being the worst pain that you've ever experienced.
No, nothing at the moment.
0 pain at
Zero
the
pain
moment.
at the
0 pain at the moment. Okay, so I've now done that. I now need to go and document what I've actually found. So I'm using here a thing called the QADS, which is a track and trigger form that is, the principles behind these are apparent in all organisations that are major hospitals. So let's have a look how these actually work. So you've got the patient details here, so this is Pam's details here, and basically there's the general instructions which all clinicians need to be making sure that they're aware of, and I will show how it works as we go through. On the front here you've also got a modifications for patients with chronic abnormal physiology. So what this means is that if there is something that a person has, such a chronic disease, let's say obstructive pulmonary disease, the registrar or the medical officer can make a modification to this saying that they are happy for the respiration to be in this range or the oxygen saturation to be in this range, and they accept that. So these modifications are only set by the medical officer and are only in place when there is a chronic disease. On the other hand, we can also have a temporary modification. So again, if there's a variation that the doctor is happy with, they can record that there. But the difference here is that these are only done for a maximum of 2 hours, and still the vital signs need to be monitored every half hour. So these sections are for doctors to be recording only. If we go to the back of the form here, we actually have a pain score, so a pain and sedation. So if the person has any level of pain, you can be documenting that pain level there. And the sedation score, if somebody's on pain management or sedation, then they can be scoring those as well. So you need to be monitoring those on a regular basis as well if your patient warrants that. So if we go over here to look at the actual use of the tool. So in terms of Pam's observations, I need to first of all look at what she's got and then document accordingly. But first let's understand what this tool actually means. First of all, you'll see a colour code. 0 is white, 1 yellow, 2 apricot, 3, 4 orangey, and purple is emergency. So these scores are given, for example, 1, 2, 3, 4. For every time that hits in that, say the yellow, it scores a 1. If it was a 1, then you totally add up the whole score accordingly down the bottom. So the score then tells us what we need to do. So if the patient had a score of 1 to 3, then we need to review the observations 4 hourly and notify the team leader. 4 to 5, we increase the observations 1 hourly, we notify the team leader or the resident review within 30 minutes, and if no review, then 30 minutes is a registrar. 6 to 7 is half hourly observations. We're getting more concerned about the level of concern for these patients because their observations are not within normal range, and we need to have a registry review within 30 minutes. And if that doesn't occur, then it can warrant an emergency call. If they're scoring 8 or above or an emergency, it is a 10-minute observation and we initiate an emergency call. I'd like to point out that purple is an emergency for any airway threat, respiratory or cardiac arrest, a QAD score of greater than 8 or greater, any observation that fits in the purple score, oxygen with less than 90% in response to oxygen, that's oxygen saturation, a seizure greater than 2 minutes, sedation score of 3, and most importantly, if you are concerned about the patient but they do not fit in any of the criteria. So for example, they could have a score of 1, but you are really worried about that particular patient, you can actually escalate. I want to also point out what this means here in terms of the blood pressure. So we know Pam from previous admissions and her previous observations today that her normal blood pressure systolic sits at 120. So as the nurse, I can write that her usual systolic is 120. If we're not sure, then we can put a default of what is considered normal for that age group of being 120. Alternatively, that is done by the registered nurse. Alternatively, if the doctor or registrar wants to have a target blood pressure, they can put that there. So once we've identified that she's 120, we then circle that whole area, and this allows us to get the colour codes accordingly. So let's now record what she had for her vital signs. And we took these vital signs at 13:30. So if we put down 13:30, we also have the date. And so when we looked at respirations, her respirations were 14. When we looked at her oxygen saturation, we saw that her oxygen saturation was 96. Now we look here at the oxygen litres per minute being delivered, and you'll note that she's actually only on room air, which is only 21% oxygen. When we look down here, the way that the oxygen is delivered, whether it be face mask, high flow, non-invasive, nasal prongs, etc., that gives us the indication of what to record here. The RA simply means room air. So she's having less than 28%, so she's actually having 21%. The blood pressure, so we've got 120 over 70, so we go 120, and the diastolic is 70. So you can actually score this like so, and you can also graph these from the previous ones as well. And then when we look down here at the heart rate, her heart rate was 62. So we can go here to here. And then temperature was 37.5, which is a bit of a low grade temperature, not that concerning yet, but I would be keeping an eye on that. I look at her conscious level. Is she alert? Is she responding only to voice? Is there a new confusion or agitation? And if there is, it's an automatic score of 4. Or if she's only awake based on pain or she's unresponsive, then it's an emergency call. But we can see that Pam is alert and orientated to where she is. We have no modifications in use. So when we score this, 0, 0, 120, we go over here, 120 equals 0. 62 is white, it's 0, 0, 0. So we've got a 0 score. There is no intervention required, and I sign that at the bottom. Let's say, for example, we did another set of observations on Pam. It was maybe, say, 4 o'clock this afternoon. So we write 1600 when we do our observations. Let's say her respirations were about 17, that she had an oxygen saturation of 98%. She's on room air, but we did notice that her blood pressure started to go up, and she also started to have an increase in heart rate. Her temperature was starting to go up even further, up to 38. She remained alert, no modifications. Let's now add up what she got. We asked her about pain, and just as we needed to record her pain from the previous observations, which I did at 13:30, so I'll write that down, and her pain was 0, so there's no interventions. So let's say we ask her again at 1600, and Pam tells me that her pain is actually at A3. So something is going on here. We notice that her vital signs have changed. She's got an increase in heart rate, an increase in blood pressure, and I'm starting to get a little bit concerned about her. So let's do the add up. 0, 0, 150 now. So let's go along here. Oh, she's just still in the 0, but she's getting close to the 1. So a 0, but she's actually heading up to the 2 there and a 1 there. So she's now got a score of 3. So what is my intervention? I need to do an intervention. Let's have a look and see what we're actually doing. So a score of 1 to 3 is 4 hourly observations or team leader. I need to consider these all in context. The fact that she's now got pain, she's got a heart rate, she's starting to get more febrile. I think she probably needs to be reviewed. It could be that she's starting to get an infection, and she could also be having some level of pain. So I'm going to notify the doctor. So doctor notified. I would check with Pam and see when she last had oral analgesia, give her some oral analgesia, and request review. So that shows that what I have done has been in response to this concern. If I ignore what is actually happening in this, this is the time when patients can start to deteriorate. So these tools provide us with early warning that things are not right. And remember, you can still escalate if you've got concerns about anything. Vital signs are absolutely vital. That's why they're called vital signs, and it's our responsibility as clinicians to make sure we're not just doing them and recording them, but we are making sense of what they mean. So how are you feeling now?
Good, thank
so
you,
I've
Karen.
given you that, so it's now 4:30. I've come back to review you. How's the pain now?
A little bit of pain there now.
A little bit of pain. So I'm going to do another set of observations based on the previous ones, and as you know, with the doctor's been to see you, etc.
Thank you.
So thanks, Pam.